Doop doop. Stop transcription. Share. Okie dokie. Much like I do with a lot of my trainings, this one is going to, it's just kind of a whim because I've encountered a handful of cardiac stuff, which was pretty interesting. And I've explained some stuff to some people, and we've talked through a couple of cases that are pretty interesting. And there's these overarching themes. So many overarching themes that they deserve their own highlights, in my opinion. First and foremost, we've been taking a little bit of a break from trainings because of a couple reasons. We've been doing some administrative stuff. We've also got the new sim mannequin, but we also transitioned the former BTEMS training that never had its own license. That was just a Microsoft account that was linked to another one, like a parent account. We now have EMS training at berrytown.org with its own license. That means that all the people responsible for training, credentialing, precepting, et cetera, the shift supervisors will all have access to the same Microsoft account. So everything will be kept in the same place and accessed through the same thing. The problem is the people that merge our accounts together are having issues moving the entire 100 and something person group that I have on the previous one to creating a group on this one. So I am recording this video using the new training thing, but you'll get it from the old one. And that's why I haven't put out any public invites, because I don't want to keep storing videos and contents on a training email that, one, doesn't have its own license, and two, is moonlighting as soon as we get this up and running. Okay, that being said, I mentioned this a couple of trainings ago, cardiac stuff, tidbits. This is what the state is going to start doing for training. If anybody's seen my trainings before, or the one that I did prior to this, they'll know that this form is required, and we need to do objectives. So topic, cardiac, tidbits, ALS. Duration, I don't know. I'm always a little bit overzealous with that. I think I'm capable of, and then it ends up on, so we'll say 1.5 hours. Maybe I could get it done in an hour. Name of delivering. Yours truly. Mickey Britannicus with him. 1.5. This is NCCP content, actually, all cardiac. There are going to be some back to basics, cardiology 101, and then we're going to talk about axes. We're going to talk about subtleties. I don't even know how to spell subtlety. And then we are going to talk about wide complex tachycardia. So that would be V-tach versus SVT, or idioventricular with aberrancy, right? Okay. Objectives. By the end of this training, clinicians will be able to better understand the origin and flow of electrical current in the heart, and how, oops. Okay, I need to make this a multi-line. Ooh, maybe I can do it now. All tools. Prepare. Multi-line. Good job. Sweet. I think we're done. Okay, better understand the origin and flow of electrical current in the heart, and how this is transcribed on an ECG tracing, i.e. 12 lead. Next, we are going to understand why subtleties exist and how they can be interpreted in relation to, oops, we're going to have to do another one. Sorry about this, friends. Just do all of it right now. Sweet, good enough. Axial statistics and how they can be interpreted in the context of electrical current / axes, how to use some of these overlapping principles to differentiate between SVT with aberrancy, i.e. wide complex tachycardia, versus V-tach. That's that. Save. Okay. Please let me know if you watch this. And I'll probably insert some random number at like a minute. I'm going to say 52, but it's not going to be 52. It's going to be somewhere in there. And then you can email me the number that I said, and then I'll assign you credit. That is the test question like this. Okay, let's get to it. Let's look at a 12 lead. Normal 12 lead. Okay. Just so everybody, this isn't meant to be condescending, but just so everybody has an idea of what a 12 lead looks like. It's wise to just become naturally or intrinsically familiar with the way that the QRS complexes point in an EKG. Up, 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 and down, 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 midway, up, up, up. So this is what's called axis. So if you have an ECG tracing that has all the numbers printed out on the side of it, it says ST elevation at the J point in all the leads. It says QT, QTC, QRS, the PR interval, as well as the axis. And that axis is displayed as a degree. That is talking about the left side of the heart. Chablam. And R wave progression is the axis of the right side of the heart. So you have axis, which is a number printed on the side, and then you have the R wave progression. I think that these two concepts are not really talked about well in pre-hospital medicine during your initial entry programs. I personally think it's a little bit of a problem. I think people approach things with a little bit of confusion, fear, apprehension, or they just get lost in the sauce, but they don't really realize how easy it actually is. So let me highlight a couple of things that are noticeable with this. Let's zoom in a little bit. Oh, it doesn't let me. Okay. See my cursor. Do you see this little thing right here? Right there. That's an R wave. Okay. And this is an S wave. One thing that's true about ECGs for the most part, especially when your patients are large, and especially when ECG stickers and leads are placed in different places across serial ECGs, I never recommend doing that because you'll have variances. You'll also have variances in the way an EKG looks if your patient is sitting up or down more than they were before, or if they're breathing all the way in and holding a breath versus breathing all the way out versus breathing really fast, and then you get a wandering baseline. So keep your patient in the same position, keep your ECG leads in the same position, and then tell your patient to just kind of like breathe slowly and not talk. One other thing is that if your patient is hairy, you actually have the benefit. If you have the knowledge of proper ECG placements, then you can shave in the exact areas you want everybody else going forward to put the ECGs. If you mess this up, people might be lazy and they might put stickers on the incorrect place as well. So all your ECGs may be weird. And we're going to talk about why this is important. Okay, so to better understand this in the axes, we need to do the daunting thing that nobody likes, which is to look at Einthoven's triangle and the axis. You do not have to commit this to memory. You do, however, have to understand the concept. So if you have the right atria, the left atria, the right ventricle, the septum, and then the left ventricle, which I like to think of as being a lot bigger. I mean, it's not even that meat I like to think of it. It just is. There's a lot more muscle here. And anything that has a lot more muscle, you know, like a horse that's a lot larger, requires more food, i.e., this requires more electricity. So naturally, the tendency of the electrical gradient of the heart points towards where the maximal impulse is, which is somewhere down here. So if your heart electrical activity originates in the SA node and then goes down to the AV node and then goes through the septum and into the Purkinje fibers, after it branches from the right to the left bundle branch block, the majority of that electrical current is concentrated in the bottom left part of the heart, right here. Okay, that's where the highest degree of ventricular contraction to eject blood during systole is occurring. This is called the point of maximal impulse. And people might tell you to listen to some sort of systolic murmur in this location. All right, so the natural tendency then is for the electricity to originate here, go to the AV node, take a little bit of a refractory pause, and then go down to this area. So the natural electricity goes like this. Draw this right here. Where's the, let's use a different color, and maybe I can make it a little bit bigger. I'm not very good at this yet. Well, whatever. So if this is what the electricity is doing in the heart, something like this, we could expect that the natural axis is somewhere between 30 to 60 degrees. Up to 90, down to negative 30 is normal. This area is a normal axis, negative 30 to 90. So why do we monitor stuff in lead 2? Because it falls kind of in the middle of a normal axis, which means it's capturing the greatest degree of heart myocardial activity that's occurring. So if you were watching a race and you had 100 runners and you wanted to see what the majority of the runners were doing, you would not look at the 10 people that were straggling behind that couldn't keep up. You would show the camera on the 80 people to encapsulate the majority of the race. The same thing is true here. You would look at the majority of the electricity that's going through the same part of the heart, and that's in this area, okay? So that being said, we monitor in lead 2 because if there's an arrhythmia, if there's no P waves, if there's a wide QRS complex, if something's weird, it's more likely that you'll notice it in lead 2. Even AVR, sometimes you could look at lead 1. So sometimes you do have to click that little button and change your leads. And we'll get into why in a second here. But you don't really want to monitor somebody in like, well, I said AVR, I meant negative AVR. AVR, because that's all the way negative. AVR is the average negative value, the negative reciprocal, or the reciprocal rather, but the negative of all of the electricity through the heart. So if the normal electricity is doing this, AVR sees what it's doing in this direction. So with AVR, this is positive. And because the electricity on average is going away from positive, that means on the isoelectric line, it goes like this. Whoa, that's crazy. Okay, so I'm surprised I drew that so straight. Likewise, when you have, we're going to make, this is a little simplified, and sometimes I get things wrong, and sometimes I just like, you know, I might make little misnomers when I speak, but as long as this makes sense and people go, oh, then I'm happy. So you got like, this is a simplistic drawing and it's not actually what's happening, but we're just going to pretend it is. V1, V2, V3. I'm going to cheat now, right? 4, 5, 6, right? If electricity is starting here, all of these leads, the precordial leads, are all positive, originating from some central terminal here that is negative, called Wilson's central terminal. Yep. So imagine the electricity flowing the same way from the SA node to the AV node down to this point of maximal impulse, ka-chow. in reference to all of these leads. In lead V1, for a very brief second, the electricity is going towards V1. Now it's going away. So lead 1, there may be a little blip it. And if you put V1 and V2 too high, which a lot of people do, they're the fourth intercostal space. That's like almost the nipple line. But sometimes people put them way up by the collarbone, right? If you put them way up here, you're going to have longer time spent going from, away from V1, which means your P wave may even be negative, and your T wave may be biphasic. That's a normal variant in V1 and V2 because sometimes people's hearts sit a little bit lower, and a lot of the times people accidentally put the two leads too high. So if you have this lead, which is a positive because all the precordial leads are positive, and then you have electricity going here, down here, it's always going away. And if it's always going away, it's primarily negative from the isoelectric line. You know, if this is your P wave, you know, but if it's negative, your P wave may even be inverted. Same thing with your T wave. They're like, oh my goodness, there's ongoing ischemia in V1 and V2. This patient is having a septal MI. Nope, you just put the EKG leads too high. So just keep that in mind. That's all I'm saying. Okay, moving on. You'll notice, though, that at some point, V3, this is going towards it, right? And then away from it, like 50-50. Somewhere, depending on your lead placement, depending on the patient's position, if they're leaning up or laying down and the heart flops forward or the heart flops back, and then if they're breathing in or breathing out, and then obviously your EKG lead placements matter here, right? If your lead is too far this way, this is going to be more negative. If it's too far this way or too far down, it's going to be more positive. So all this affects where your R wave transitions. So if you have a little notch, which this is something that I don't think people realize, that is an R wave. See how small it is? That is an R wave. Because if that wasn't an R wave, this would be a Q wave. And Q waves are never normal. Q waves are pathologic, and we're going to get into why later. So this is an R wave. It's just very, very small. Then as you get into here, a lot of the electricity is going towards V3. So that goes up. But then an equal amount is going away. So that goes down. This is called the R wave transition, where the R wave is transitioning from primarily negative to primarily positive. And somewhere between V3 and V4, it's about 50-50. Okay? By the time it gets to V6, the electricity is all going towards it, which means it's all positive. The exception to this is if you have an enlarged heart, because you're not going to change where you put lead V6. It's the same on everybody. The mid-axillary line at the fifth intercostal space. But look how much more tissue you have here, which means even on V6, some of the electricity is going to be going away. So if somebody has an enlarged heart, not only are they going to have huge QRS complexes, they might actually have an S wave. And maybe even some sort of T wave, a depolarization abnormality. Because as it repolarizes, it should be entirely positive. But that's assuming the heart ends here. If the heart ends here past it, you might have a negative area, right? So you might see this little like negative dip area where the heart is actually depolarizing away from V6 and then towards V6. So anyways, keep that in mind. So you are going from primarily negative to 50-50 in by V3, V4 to primarily, oops, I should draw the isoelectric line, to primarily positive in V5, V6. That is called R wave progression. If your R wave is, let's say you have like a big R wave, and then it doesn't actually transition until lead V5. Let's say you still have an S wave by V5. This is delayed R wave progression. Delayed. If your R wave is primarily positive, and then, wait, maybe I did that backwards. I'm sorry, let me rephrase that. If you still have a large S wave like you would in V1, you really never transitioned. That is delayed R wave progression. If you transition early, like by the time you get to V2, you're already like primarily up with a little S wave. This is early R wave progression. There are benign reasons for this, and then there are pathologic reasons. Usually, if somebody calls 911 for a heart condition, and then you see abnormalities to any part of the EKG, you should assume that it's occurring because of their cardiac symptoms. Unless you can point it to something else like COPD, breathing difficulty, sepsis, hypoperfusion, or anything like that. So let's get into it a little bit. A lot of people, you see this like ST depression in V1 through V3, and you're like, oh my goodness, that is a posterior MI. Let's do a 15 lead. Why is a 15 lead, in my opinion, even necessary? Because how many times do we place stickers on people's backs? Not very often. So do you know for sure that that leads 13, 14, and 15 are actually in the right place? No, you don't. There's also more tissue between the heart and the back than there is between the heart and the chest, assuming you're not placing your leads over a large breast tissue or somebody who's substantially obese, or you're not placing the leads too low on somebody's belly. So on average, you're going to get lower gain, which means if your QRS looks like this, on the back, it's going to look like this. Okay? So it's harder to analyze an ECG when the gain is poor. Okay? Likewise, you may place the leads wrong, which skews what your results look like. Thirdly, there's a lot more bone in the back. Do you know what it's called? The shoulder girdle. Oh, yeah, the scapula, okay? And then the teres major and the teres minor, and then all of the lat muscle is here, and then you have the erectae spinae muscles and the rhomboids, and like all of this, there's more muscle back here. So you're likely to get abnormal views of leads 13, 14, and 15 if you do a 15 lead, whereas if you just assume that if you did it correctly, this would be positive. And it's way faster. So don't even waste your time, in my opinion. I'm not telling you how to be a clinician. I'm just saying that this doesn't make sense to me. But let's talk about reciprocal changes, okay? Do we all agree that ST depression, if you see it in V1 through V4, the anterior area, is equivalent to ST elevation posteriorly, right? If you had a flipped P wave, that's a bad example. Anyways, forget I said that. Likewise, if you had a Q wave in lead 3, and you're like, okay, this person has had a heart attack at some point in the past, or has one ongoing, because this is just a refractory error. It's cardiac remodeling or some sort of depolarization abnormality where electricity is not being conducted through an injured or dying or dead part as well as it was before. And as that progresses, the Q wave gets bigger and bigger and bigger, and then you have what's called pathological Q waves, where these persist in the absence of ST elevation or T wave inversion or hyperacute T waves. That's what a Q wave is. And so let's do this. Let's say lead V2 and V3. By lead V3, half of your R wave should be up, your QRS complex, and half should be down. Normal transition. And V1 should look actually like this. Very small R wave, right? What if you had a large R wave in V1, like this? Could this be the posterior equivalent of a T wave? Because we just said that ST depression is the posterior equivalent of ST elevation, right? So why isn't an anterior R wave potentially the posterior or reciprocal equivalent of a Q wave? So if somebody has ST depression or T-wave abnormalities in V1 through V4, and they have chest pain or ACS symptoms, or they're sweaty, or they're bradycardic, or their blood pressure is bad, or they're nauseous, or anything like that, and you can't identify a primary cause like a breathing problem or sepsis or hypotension, or cardiogenic shock, which I guess obviously cardiogenic shock and hypotension could be caused from an MI. But if you're like, this is primary cardiac, I can't find anything else on my exam of the patient, I'm presuming that this is primary cardiac, and you have ST depression here, or T-wave abnormalities, and a large R wave where there shouldn't be one, that might be the posterior equivalent of a Q wave. So if you said that this person has early R wave progression, because see, there's an early R wave, that could be an indication that there's an ongoing MI. So you see how acknowledging the normal transition of R wave somewhere around V3 is important because it could indicate pathology, right? Likewise, what if somebody had a beat originating here going up? That's called V-tach. Oh yeah, V-tach. Wouldn't that person potentially have downward facing QRS complexes in V6 and upward facing QRS complexes in V1? Couldn't that be opposite? Yeah, it could. This is backwards R wave progression. Oh yeah. Now, what else do we have? We have delayed R wave progression, where it's like this, V3, V4 looks like that, V5 looks like that, and it never gets up right. What can cause this? Benign things like bundle branch blocks, left ventricular, specifically the left ones, left ventricular hypertrophy, any weirdness with pacers can cause weird stuff like that. We're not going to get into the weeds with that during this talk. And then what else? Yeah, any repolarization abnormality or aberrancy can cause weird stuff here. And that's another part of this conversation. So let's get into it. The point is, acknowledge if the R wave is not transitioning where it should, because either the patient's in a weird position, you placed the leads wrong, the patient's heart is flipped because they have whatever that term is called, where the heart is transposed to the other side, or they have V-tach, or they're having an MI. Something's weird, right? Right. So now here's the cool thing. Here's the meat and potatoes of this talk. Pay attention to this. Lead 1. Lead AVF. Do we agree that the lower and upper limits of the normal axis, sometimes you can get into AVL, but for sure lead 1 are leads AVF and leads 1? I think so. Okay, 0 degrees, 90 degrees. Positive lead, right? Meaning this should be positive and this should be positive. So lead 1 and AVF should all be positive. Lead 3 could be a little bit negative. So when you look at a normal 12 lead, you see positive, positive. I wish you guys could all see my thumbs. So let's do the thumbs up method, okay? Imagine you point your thumb up here, and then imagine you point your thumb up here. These, because this is lead 1, the upper limit, and lead AVF, the lower limit of a normal axis. There are various rules out there, but this is my favorite because it makes the most sense and it's the easiest to remember. If lead 1 is up and AVF is up, that's 2 thumbs up. That means you're good to go. The axis is normal. If lead 1 is up and lead AVF is down, what thumb is left pointing upward? The left one. The left thumb is up and the right one is down. Left thumb up, left axis deviation. If this is down and then your right thumb is up, which thumb is up? Your right thumb is up. Right axis deviation. If both are down, bad news bears. That is extreme axis deviation, which is over here. What's extreme axis deviation? AVR. Okay. So if you look at lead AVR, which should be entirely negative, because all the electricity is going away from it, but it's positive now. That could be an indication that you have V-tach. So let's get into a little bit of the meat and potatoes of this. V-tach, SVT with aberrancy. So we're going to kind of do a generic thing, and I might get a couple of these. There's no such thing as a 100% rule in medicine, right? So even though I'm going to put a lot of things on the column of V-tach and a lot of things on the column of SVT, you could have columns on the V-tach, but the patient could actually have SVT. The only way to diagnose it, truly diagnose it, is to do an echo, specifically a transthoracic echo, which is read by a radiologist and a cardiologist. That's really the only way to know where the, even but a bedside echo, like a fast exam, that could do it. So things that favor V-tach. Let's start with the most obvious. Really old people, because they have structural heart disease, like MI, cardiomyopathy, apathy, previous MI, heart failure. Oh yeah, all that good stuff. Okay, structural heart disease, really old people. Yeah, okay. Oh, if someone has an MI, right? If they have specifically a left-sided MI. If your patient needs a left-sided heart cath because you have elevation in V1 through V6 or leads 1 in AVL, they are likely to have a V-tach or VFib arrhythmia. So if you diagnose a 12 lead and you're like, oh my good golly goodness, that's a STEMI, and then their rate is fast and wide, I would presume on the left side of the heart that is V-tach. If somebody has a right-sided heart attack and the SA node is affected, they could go into AFib, aflutter, bradycardia, whatever. The right side's a little bit more difficult to diagnose. But on average, if somebody's heart is affected on the left side of the 12 lead and you're like, oh, V3, V4 have ST elevation and T-wave invergent, and they have chest pain and they're sweaty and they're vomiting, right? So you activate the cath lab and then they go into this wide V-tach looking thing, probably V-tach, right? Okay. What else do we have here? You know how people talk about if the QRS is wide, what does that actually mean? What that actually means is the space from the R wave to the nadir of the S wave. If that is greater, now it changes depending on your sources, than 100 milliseconds, then it's more likely to be V-tach. But people don't want to do this measurement, and the auto interpretation of the ECG just tells you the QRS duration. It doesn't tell you the R wave to the S wave. Okay, so the reason why that's important. Let's go back to our 12 lead. Oops. All right, R wave, the nadir of the S wave. R wave, nadir of the S wave. This is where, let's find, oh, here's one that's right on the line. This one's not even one box. That's 40 milliseconds. Okay. Just like the R wave progression, which means that the heart is going, that the electricity is going from, where's my drawing? This one's fine. Here to down here. If it's going here, up and away, then everything's backwards. The R wave progression is affected. So on your 12 lead, if you take the precordial leads and you look at the R wave to the nadir of the S wave, if that's greater than 100 milliseconds, it favors V-tach. The reason why the generic rule is like QRS that's wider than 120 is because the auto interpretation of the machine gives you the reading, and they lump this first part in with the R to the S wave, and they add 20 milliseconds for that part, and they assume that the refractory error is 100 milliseconds. So if you look at a QRS that's above 120, there is a likelihood that the R to S included in that is greater than 100. But that is the problem, because the R to S is often greater than 100 in conditions that are not V-tach, such as aberrancy. So the true diagnosis is to actually count the boxes from the R wave to the nadir of the S wave. Okay, so get into the habit of doing that. Now, moving on. What else? Any superimposed P wave. If you see random P waves, let me show you what that looks like. Superimposed P wave V-tach. Oh yeah, good drawing. P wave, P wave, P wave. They're in different places, no rhyme or reason. They're not associated with the QRS complex. That means they're discordant. That means that the atria are firing separately. And if you actually measured here to here to here, it would probably be the same distance. That means that the P waves are firing independently, or the atria are firing independently of the ventricles. When does that happen? In V-tach, sometimes. Not all the time. Sometimes the atria aren't firing at all. So you may not have this, but it's something else to look for. Oh, and then here's one that I would have forgotten if I didn't see it. Capture beats or fusion beats. If a combination of a normal beat meets with a ventricular beat, and then it makes this little blob in the middle, that's a fusion beat. A capture beat happens to be when the P wave independently generates one normal QRS complex, and then everything else looks abnormal. That's a capture beat. Okay, so these favor AV node dissociation, otherwise known as V-tach. But only 60% of monomorphic V-tach presents with this. So it's not a 100% rule. Let's see. So then we have the capture beat and the fusion beat. We also have the rate. Like a V-tach at 180 to 100, possible, not likely. A V-tach at a rate of greater than 250, patient's probably dead. Somewhere between like 140 to 150 and like 180 to 190, that could be V-tach, right? So there are slow V-tachs, there are fast V-tachs, but slow V-tachs are easier to analyze because there's more space between, so you can see more stuff. You can truly see the absence of P waves. You can truly assess if the R to R is regular or irregular. Okay, SVT with aberrancy. What favors that? Younger or diagnosed or known fundal branch block. Let's see. Rate induced ischemic pattern. Here's the analogy I use for this. Everybody knows about the bridge on North Payne Turnpike. At least I hope you do. How do I make a new page? Or clear everything? Maybe I'll just do Control-Z for a long time. Sweet. The bridge on North Payne Turnpike. It's small, but it works. If you have the ambulance going through at 55 miles an hour for a cough, because we got to kill people on the way to a cough, it could probably get across the bridge okay. If you're coming from the hospital and you're going 50, 60 miles an hour this way and there's no other traffic, probably gets along okay, right? Now let's say there's like a car a minute going each side. Every once in a while they get kind of close, but they can wait. So traffic's not really getting slowed down, right? But now let's say we have a parade on both sides, parade going this way and a parade going this way. You bet your butt that there's going to be a significant slowdown or a prolonged time for those vehicles to get across. It's going to be a traffic jam. Now, because it takes longer for the vehicles to get across, how is length or time represented on an EKG? The x-axis. P wave, QRS, T wave. This is time. Time, ka-chow. The more cars, i.e. the more beats you have in this area that works, but it doesn't work as effectively as if it was just a normal road without the bridge, that is a rate-induced area of ischemia. Okay, it's not a full bundle branch block. Okay, a full bundle branch block, your traffic wouldn't be getting through at all. The whole road is messed up. This is a temporary bridge where the effects of which are only seen when traffic is at a high rate, i.e. greater than 140, greater than 130, greater than 150. I don't know. Depends on the person. Depends on the bridge, right? So if you have the more traffic you have, i.e. the more beats you have, the more likely it is for you to experience a delay. So this is how you can think of a rate-induced aberrancy. If somebody's heart is like this, and then all of a sudden they have this fast part, and it looks like that, and their blood pressure is not weird, and they're not super symptomatic, and they're not unresponsive, and they're not pale with a ton of chest pain, this is probably just a rate-induced aberrancy. Sometimes the rate-induced aberrancy even flips over. What's that analogous to? Well, let's say a truck starts to go here and a truck starts to go here. Both of them realize that not all of them can win, so this one backs up, goes backwards, right? So your QRS complex that's like that, for that car going backwards, might look like this, and it might be wide. So it can be easy to think of rate-induced aberrancies, especially when you see, if you're watching just lead 2 and you don't take a 12 lead, and it's like bing, bing, and then all of a sudden it's like bing, 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 bing. You might be like, oh my God, the primary R wave changed from upwards to downwards, and now it's fast. The polarity has switched, and therefore I deem my patient in V-tach. And then you shock them and you didn't really need to. Why didn't you need to? What's the underlying cause? Pain, sepsis, infection, inflammation, COPD, breathing problems, hypotension. All of that stuff that can cause tachycardia. If you don't fix that first, then you have no way to know if this is a primary cardiac problem or a secondary cardiac problem. Okay? Okay. So that's my little blipid about rate-induced aberrancies. Please look that up on your own if you want to. Okay. Moving on to axes. More axes stuff. So I like to think of axes as a flashlight. Let's pretend that a flashlight is pointing here. Okay. This is what the flashlight is primarily looking at. Do you think you could see someone making some room over here? Yeah, maybe you could see their arm, or you could see it's like, yeah, I know it's a person. I know it's a guy. I know it's a girl. I know they're robbing me, but I don't really know exactly what they're stealing, right? Like something like that. You know, you get over here, you're like, I don't know, are they sleeping or are they talking? I can't tell if they're on the phone. I can't tell if they're eating. They're doing something, but I don't know what they're doing, right? So you know, just because your lens is viewed primarily this way doesn't mean that this stuff is entirely out of view. But here's what I will say. Let's go back to our 12 lead. Oh, that's my example. Don't want to give that away yet. So, by the way, I have not looked this EKG up yet, and I have no idea what the actual diagnosis is. So if somebody like reverse image searches it and then I happen to be wrong, okay, that's great. I'm just trying my best to say stuff that makes sense, okay? Like on average, if your patient is unresponsive, hypotensive, and their heart rate is 180, it's pretty unlikely that that is due to something that's not primary cardiac. You could probably cardiovert them and be totally fine. You know, if your patient's heart rate is 130 to 140 and it's irregular and they're a little nauseous, but they have a bowel infection or they've been vomiting all day, and you give them amiodarone, that might be a problem, okay? Especially if they're on a pre-existing channel blocker. If somebody's on a beta blocker and then you give them a calcium channel blocker and it's a secondary problem, right? Not a primary cardiac problem, but their heart is fast compensating for something else like a fluid deficiency or infection or fever or pain or sepsis or hypotension or anything like that, and then you give them another channel blocker, oh boy, guess what you're going to do? you're going to cause hypotension. And if that patient has structural heart disease and a lot of pre-existing comorbidities and badness, you could even cause them to go into cardiac arrest or this thing that's called dying of death. So don't do that. The name of the game is figuring out if it's primary tachycardia or secondary. That's it. If it's primary and they're unstable, no question, you can cardiovert them as long as you hit the sync button. If it's ambiguous, you can call medical control. If it's like, yeah, we're on the fence. Here's a thought. If you're on the fence and the heart rate's 130, you could probably get away with bringing that patient to the hospital without doing something. If it's ambiguous or in the middle, but the heart rate's 180 and you're 40 minutes away, it might be harder to explain to the receiving physician that you sat on an ischemic, especially if there's ST depression, that you sat on that heart rate for 40 minutes without doing anything. Because then you kind of look like you don't really know what to do in those instances. You look a little bit incompetent. So if it's ambiguous and your patient takes a beta blocker, here's an idea. Give them more of it, right? Could they not have taken their medication for a couple days? Could their medication be outdated? Could they have stored it incorrectly and now it's no good? Do they have a GI infection, gastroenteritis? Have they been vomiting or had diarrhea? Is their GI system inflamed, i.e. the absorption's not great? Do they have a renal problem or a hepatic problem and they're not digesting medications appropriately? I don't know. Maybe. You want to know what you could do to help augment that? You can give them the intravenous version of what they're not successfully taking orally or what's not successfully being digested. Here's another thought. Maybe they just need more. Maybe they were on 12.5 milligrams once a day, and now they need 25 milligrams twice a day oral. You can give them 5, maybe even 10 milligrams IV, and it could fix their rate. I'm a fan is if something's ambiguous in the middle, and it's like, they could become symptomatic in a little bit, but they're not so bad that I need to cardiovert them and it's not black and white. But you're like, I don't really want to sit on this patient for like 30 minutes because then somebody's going to be like, dude, what the hell are you doing? Not doing anything for 30 minutes. Why aren't you doing your job? Right? But we don't have echoes. We don't have access to electrolytes, patients' previous medical records, previous 12 leads. We just have what's in front of us. So your primary job is to figure out if it's primary or secondary cardiac. Is it compensatory or is it a primary cardiac problem? Your next job is to figure out how unstable or stable they are. If they're stable, don't worry about it. You don't have to do anything. If they're horribly unstable, no brainer, zip zap sauce coming at you, full speed. If it's in the middle, if the heart rate's 140, maybe you can get away with doing nothing. Give them a fluid bolus. Try that, right? Maybe try adenosine if it's fast enough. If it's 180, 190, that's a little bit fast. Hey, what do you take for medication? I take metoprolol. Oh, I can give you more of that. I take lisinopril. Well, I don't have lisinopril. Let me give you something that's judicious. Like, let me give you adenosine because I don't really know what's going on. I don't want to take away channels, but I can slow your AV node down because your AV node will fix itself after like 10 seconds, right? So I'm always concerned with knocking out pillars, beta blockers, calcium channel blockers, all that stuff. Sodium channel blockers, right? So if you give somebody DIL and lidocaine who is on a beta blocker at baseline, you're probably going to interrupt so many cardiac pathways, channels, that they could go into a horrific degree of AV node block or bradycardia or even asystole or some sort of lethal arrhythmia, or at the very least, you make them horrifically hypotensive and now they require pressors. Just a little bit of pressors? No, probably not. Probably more pressors than what you would normally need because you gave them beta blockers too. Now you need twice as much Levophed to get the same effect. Okay. So like I've always been cautious of delivering multiple nodal or channel blocking agents to the same patient when I don't know what they take. I don't know what the full hits cardiac history is, previous 12 leads, lab work. Do they have an infection or an underlying problem that's causing the compensatory tachycardia? And then what does the echo look like? Right. So, put the paramedic ego aside every once in a while and just decide for yourself, do I really have to treat this? And if the answer is yes, or if it's 50-50, but you're leaning a little bit more towards the yes, it's the more cautious and judicious thing to do is to err on the side of caution and give the patient more of what they're taking. If they take oral diltiazem, give them intravenous diltiazem. If they take oral metoprolol, give them oral metoprolol. We don't carry labetalol, but that's what I'm saying. A lot of people take metoprolol even for AFib, or they might even take amiodarone. If they take amiodarone, give them gosh darn amiodarone. And if you're very confused about it and you don't know what to do, call med control. Okay, so getting back on track here. So remember my thumbs up, thumbs down rule? Let's say that my patient or your patient has right axis deviation. So let's do our thumb rule. Would this one be up or would this one be up? This one would be up and this one would be down. Right axis deviation. Okay, now let's go back to our heart. Right axis deviation. The axis is going from here more towards here, the right side. What if you had a left-sided MI and the patient had right axis deviation? Now the flashlight's over here. Now you know something's going on over here, but you don't know if they're robbing you, sleeping, cooking dinner, reading a book, talking with friends. You just hear commotion coming from over here. So what does that look like on a 12 lead? What if in V6, in a normal axis patient where the axis is going like this, you see this? You're like, whoa, that's a STEMI, right? But what if, and you need 2 or more millimeters of mercury elevation? What if you see this? What if your gain is poor and you see like 1.5 and then maybe like a weird biphasic looking T wave?
Well, that technically doesn't meet STEMI criteria because it's going to be at least 2 millimeters of mercury of more, and even if it's 1.99999999, that's not 2, and a textbook said 2. It says it has to be 2.
Right? So what if your patient had 1.5 millimeters of elevation and you measure it from the, you see the little readout on the side of the EKG, but you have horrible right axis deviation, right? That means that this is not the full picture because the lens is viewing over here more than it normally would. So if you could somehow fix the axis and put it back towards here, you're going to magnify this area, which means that this 1.5 millimeters of elevation is probably going to turn into like 5 millimeters of elevation. Okay? In contrast, what if you had left axis deviation and you had a right-sided MI? And then you saw this little baby QRS complex and like 0.6 and a big T wave. But the elevation at the J point on the measurement says 0.64. But they got lead 3 looks like that in AVF. Looks like that too. I tried to draw like a wide bulky T wave. Let me do that again. and then this one maybe is like 0.72. You're like, well, those G waves are kind of wide. Look how much space I can fit underneath it. That's a lot of space. That's a wide, bulky T wave. But you have left axis deviation, right? Because lead 1 is pointing up and lead 3 is pointing down. I guess I should have drawn that pointing down, huh? Let's make it more realistic. Let's say it looks like this, right? And you have some flat or T wave inversion or some abnormal looking T wave. And then you're like, let me check lead AVL. That's the reciprocal part of the heart. And then lead AVL has some craziness like this, which should not have a T wave inversion, but it does. Whoa, we have borderline ST elevation here. We have a reciprocal change here in AVL, and the axis is going away. So this 0.64, if the axis was normal, would probably be like 1.5. So this is a concept of proportionality. If you have a small QRS complex, a little bit of ST elevation is more. Okay, 0.7 with a little QRS is the equivalent of 2. right? Now let's say you have a huge QRS complex. 2 millimeters of elevation may be normal. You can use Smith's modified Scarbosa criteria for this. You may need 6 millimeters of elevation for it to be considered excessive. Okay. Likewise, small and big T waves, proportionality. Big, bulky T waves are hyperacute. Now, the other thing that applies is access. Okay. Borderline ST elevation on the right with left axis deviation, bad news bears. Borderline ST elevation on the left with right axis deviation, bad news bears. Yeah, makes sense. You know, you see people fighting, you don't know how bad they're getting beat up because you can't actually see them hitting each other in the face, but you know people are fighting. So you know it's not good over there, but the light's over here. And if you're like, dude, just shine the light on them, right? And you're like, oh, holy crap, he's beating the crap out of that person. So that's the analogy here, or the, you know, that's what I'm trying to get at. Okay, so let's take all of our examples and let's put them all together on a 12 lead that I have not analyzed yet, but I saw it on Facebook and I downloaded it. And here we go. I never really finished this. Younger, diagnosed bundle branch block, rate induced ischemic pattern. Obviously, we have the rate, right? Like if the rate is 260, that's probably too fast to be V-tach. Could be, but it's probably too fast. What else do we have? If you see P waves in the same place, even if they're like flipped or something, that could be an indication of SVT. If you see an R wave that's primarily pointing down because it's negative, that's more likely to be SVT. If you see a traditional bundle branch block pattern, that's more likely to be SVT. If you see that the T wave is discoordinate with the QRS complex, so if the QRS is up, the T wave's inverted. If the QRS is down, the T wave is up, right? That's more likely to be SVT. If you see actual ST changes like ST elevation or ST depression, typically you don't see that in V-tach. That's more likely to be SVT. And if your axes are normal and your R wave progressions are normal, that's more likely to be SVT. So what I like to do is take the totality of all of this and come up with a point system. You get a point every single time somebody goes onto V-tach, and you get a point every single time somebody goes onto SVT. And then you add these, unstable versus stable vital signs, right? Horribly unstable vital signs, probably V-tach. So let's say you add all of these up and you're like, boy, I've got a plus 10, on this side. And I've got a plus 2 on this side. And my patient's unstable. V-tach. All day long. Let's do a trickier one. Let's say you get 4 points on this side and 3 points on this side.
Well, 4 is greater than 3.
Remember I said that some of these aren't always black and white, but your patient's stable? You may want to wait on this patient and just watch them. Okay, because even though they technically have one more point on the V-tach side, it could definitely still be SVT. Likewise, if you had it like this, and they had a couple more points on the SVT side, that could definitely still be V-tach. A complex one to explain is outflow tract tachycardias. Specifically, now look this up. This is a tangent. Look it up on your own if you want to. Right ventricular outflow tracts tachycardias are V-tachs, and they're present about 80 to 90% of them are right outflow tract tachycardias. They don't look super wide like normal V-tachs do. They also have extreme axis deviation and a bundle branch block morphology that looks weird, and we're going to get into that too. Actually, I'll just say it right now. You're looking at lead V1, and you're like, this person has a left bundle branch block and it's wide and it looks like that. That's a left bundle branch block. This person has a right bundle branch block. And you get the bunny ears. And especially if they have a strain pattern, you get this little ST depression and like a T wave inversion or a biphasic T wave in V1, V2, V3, that area. That's a right bundle branch block. Remember how we were talking about how things are backwards when you look at the posterior part of the heart? Well, things are also backwards in V-tach. Because instead of starting up here and going down there, it's starting down here and going up there. So things are backwards. So what if you had a right bundle branch morphology, but this part was taller? That's backwards. The R prime should not be bigger than the R wave. Well, why is it backwards? Well, maybe the electricity is going backwards. Yeah? Yeah. Keep it in mind. All these little things give you a point on each side, so you can be like, huh, that might be V-tach. Okay. I think I beat that to death enough. So let's do an example. Where is my example? Here we go. I downloaded this from the interwebs, and I legitimately have not looked at it yet. So we're going to go through all of the rules, just like we talked about. Okay. So what's the rate? It's pretty fast. The way that I like to do the rate is to find one that starts like right around the big line, like this, and count away from it. So right on first glance, this appears regular. Okay. You also have an R prime that's slightly larger on the right side. Interesting. See, right here too. This might be V-tach. Okay. So this one is right on the line. 5 boxes, 6 boxes, just over 7 boxes. Actually, no, about 7 boxes, because this starts a little over the line. So 7 boxes. If you want to take out a calculator and go 7 times 0.04, 0.28, and then divide 60 by that, 60 divided by 0.28, ka-chow, 214 beats per minute. That is pretty gosh darn fast. That's kind of like right in between the ambiguous part for SVT versus V-tach. So this one, in my opinion, the rate is inconclusive, but it's definitely fast. And no matter what, if my patient was symptomatic, they're getting the zip zap sauce. Period. Okay. So that one didn't really tell us much. Let's look at the axis. Lead 1, halfway up. Actually, it's more down than it is up. So this gets more of a thumbs down. Okay. Now let's look at AVF. Oof. It's down as well. In my opinion, this is almost extreme axis deviation, 180 degrees backwards, and AVR primarily up. So if AVR is primarily up and there's right axis deviation, if that means that it's more likely that the electricity is going from here towards AVR, because AVR is up, and it's almost extreme axis deviation. It falls in this range. So we get a point for V-tach there. Also, this is exceedingly wide. So which one are you going to take which lead are you going to use the R to the nadir in? Well, it's going to be tough with this one because these are overlapping. So we're probably not going to use lead V3 because the monitoring lead of V1 is overlapping with it. So take V3 out. V2, you don't really, I mean, there's a really big R wave, but there's no real nadir of the S wave because this is just a T wave. So we're not going to use leads V1 and V2. Conversely, we're not going to use lead V6 because it's also overlapping with the monitoring lead of V1. So what leads are we left with? Well, we're kind of left with either analyzing it from lead 2 or lead probably V4, V5 if you wanted to. So let's zoom in a bunch and let's just pick one. Honestly, V4 kind of looks pretty good. And let's count. Let's find an R wave that starts right on the line, like this one. No, that's before the line. Well, there really aren't any. That's okay. This starts right at, okay, look at see the top pointer? Right there. That's the start of the R wave. So that is 1 box in. Now, where does it end here? Well, that's 1 box, 2 box, 3 box, 4 box. but it started at 1. So there's 3 boxes between 1 and where this is. So calculator. 3 boxes, 0.04 times 3 times 100. Oops. That's 120 milliseconds. 120 milliseconds from here to here. That's greater than 100. That favors V-tach. Likewise, let's look at the R wave progression. It should be negative here. Remember our drawing? Negative, but it's positive. Why would it be backwards? Maybe because the electricity is not going from here to here, it's going from there to there. So up, up, down, 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 down. That's entirely flipped backwards. It could be, so V-tach, it could be all upward. So unidirectional. That favors V-tach. If this is up, 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 or down, 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 that favors V-tach. As well as totally reversed, starting up, ending down. What's never V-tach is when your R wave progression is totally normal. The exception to this rule is that confusing right ventricular outflow tract tachycardia that I just mentioned, but we're not getting into that. Look it up on your own. So all things considered, we have an R to S nadir that's greater than 100 milliseconds. That varies V-tach. The rate is ambiguous, but it is pretty fast. If it was 120, I'd lean less towards V-tach. So I'm not really going to give it a point on either side because that rate is right in between where I kind of draw the line between being too fast to be V-tach. There is an R prime that is greater than the R wave. That favors V-tach. There's extreme axis deviation. That favors V-tach. AVR is primarily positive. That favors V-tach. And the R wave progression is reversed. That favors V-tach. So I think this is V-tach. Yep, I certainly do. I could be wrong, but that's how I would treat it. What would you do if your patient's horribly symptomatic? Give them some electricity. If they're like quasi-symptomatic, I'm not really a fan of nodal blocking agents like adenosine if I truly, truly suspect V-tach. If I truly suspect V-tach, but I'm unsure if it's a wide complex tachycardia with aberrancy, I'd be probably more likely to use amiodarone or procainamide than I would be lidocaine. Probably procainamide. I definitely would not use a nodal blocking agent or a beta blocker or calcium channel blocker. If I'm going to do anything that might hit both pathways just in case it truly isn't V-tach, it would be amiodarone or a procainamide. Probably procainamide, followed by amiodarone, followed by electricity. I mean, you can give this patient, if they're lightheaded, well, you know, and let's talk about the rule of proportionality again. What if your hypertensive 75-year-old patient that hasn't taken blood pressure medication in a year has a blood pressure of 100/54? That might be relatively hypotensive for them. I might electively cardiovert that patient, especially if you're far away from the hospital and their blood pressure has enough wiggle room to where you can give them sedatives. In my opinion, that's a cardioversion patient. Maybe. If you're concerned about it, either write it in or contact med control. But a rate like this, I would be worried about rapid clinical deterioration. So I would probably treat this very minimum with medication, maybe fluid bolus, and then have the pads on them. So that's that. Let's summarize everything we talked about really quickly. We did back to basics. We looked at what an EKG normally looks like. We got into the R wave, and we got into what a normal access is and why. Next, we said subtleties exist and they can be interpreted in the context of electrical current in the axes. How we did that is we said if the axis is pointed all the way to the left, thumb up here, thumb down there, and then you have a right-sided MI, your right-sided MI might be borderline. It might not quite meet the 1 millimeter STEMI, whatever criteria that it's supposed to there. Conversely, if you have right axis deviation and you have these weird EKG changes over here on the left side of the heart, circumflex area, but it doesn't quite meet STEMI criteria, but your patient has ACS symptoms and it looks questionable, that's a subtlety. Rule of proportionality. If your QRS complex is really, 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 really small, and you have like borderline ST elevation, like 0.8, 0.9 millimeters, a weird bulky looking T wave. Did you know that if you have any ST elevation change in here with a big bulky T wave and any ST depression, T wave inversion here, and your patient has ACS symptoms, there's a 95% correlation with an RCA occlusion just from these two leads alone. So that's not even two or more contiguous leads. That's just lead 3 with reciprocal changes in AVL. Likewise, if you have huge QRS complexes, who has huge QRS complexes? Patients with left bundle branch blocks, patients with left ventricular hypertrophy and cardiac myopathies, patients with pacemakers, and your athletic hearts, patients that have cardiac enlargement from being an athlete or running or whatever they're doing. You need more ST elevation to call it a STEMI. The principle behind that is scarbosa. And then we got into some subtleties between wide complex tachycardia with aberrancy, SVT, or V-tach. We talked about how the axis would be normal versus extreme right. AVR is going to be positive versus negative. Superimposed P waves versus no superimposed P waves. A wide QRS complex, but we distinguished that measuring the QRS complex is not as simple as just reading what the thing over here says. You actually need to measure from the beginning of the R wave to the bottom of the S wave, which is known as the nadir. Okay, we talked about the R wave progression and how a tall, abnormally tall and persistent R wave may indicate the reciprocal finding of a Q wave. That might be delayed R wave progression. I'm sorry, early R wave progression. Conversely, we talked about, well, what if it happens really, really fast? Well, I don't know, maybe your patient has a bundle branch block or some other electrical abnormality that's benign. So pay attention to R wave progression in the setting of anything cardiac. Pay attention to access in the setting of anything cardiac. Pay attention to the true width of the R to the S, not just the QRS complex. And then if your rate is regular and fast, it's more likely to be V-tach. If it's irregular, it's more likely to be an irregular SVT with aberrancy or other like AFib or A-flutter with a bundle branch block. Rate-induced ischemic patterns. Remember, I gave the bridge example. And then superimposed P waves. We talked about that. And then what else did we say? We said fusion beats and capture beats. And then I also offered an extension of knowledge, an olive branch, if you want to go look this up on your own, called right ventricular outflow tract tachycardias, which let's just look one up real quick so you can see what it looks like. All right. Well, it's not very big. Okay. Here we have a right bundle branch-ish looking thing, but see the notches here and here? That's not what a right bundle branch block is supposed to look like. That's a weird, sorry, left bundle branch block. Weird looking left bundle branch block. So abnormal left bundle branch block, with normal left axis. That's a bad example. I don't like it. I'm going to use another one. Oh, Life in the Fast Lane. They're my favorite because they have all the stuff. Okay. Let's see what they say, actually. Feeling lazy. Left bundle branch, RS complex, and V1. And, oh yeah, so an RS complex. In a normal left bundle branch block, you won't see an RS complex. It's just it's just a and an R complex. Okay, I guess I would need to do a little bit more research on that. Precordial transition usually happens greater than V3. And an inferior axis. Interesting. Well, that looks kind of like a normal axis to me. There's definitely an RS. That's definitely a huge R wave with no S wave. Precordial transitions late. So these ones are tough. That's the point. If you can recognize a right ventricular outflow tract tachycardia, kudos to you. I find, though, that you look up something like this once and then you hyperanalyze everything looking for this, and then you diagnose this when you shouldn't. But yeah, it just all looks weird. It's an atypical left bottom branch block appearance. There's like notches everywhere. And then there's definitely an RS wave that extends into here. And then it goes, there's like zero transition. It goes from all the way down to like all the way up with 0, 50, 50. That's the thing. It's lost. It still has a transition, but none of the leads are 50, 50 like they should be. So weird left bottom branch looking morphology with a weird R wave transition, that should not happen in the setting of a normal bundle branch block. In the setting of a normal bundle branch block, your R wave progression should be normal. So here we get into R wave progression again. This is an early R wave transition with 0 leads that show a 50-50. The 50-50 is supposed to happen somewhere between V3 and V4. So that's that. Okie dokie. I think that is enough. Let's see how long we've recorded for. 1 hour and 16 minutes. Oh, it's on the plus side of an hour and a half. I will count it because I'll assume that everybody's going to do research on right ventricular outflow tract tachycardias, and then they're going to go to Wave, Maven, SVT with aberrancy versus V-tach, and check out some example cases and maybe spell better than me. Where was Wave Maven? Come on. Anyways, it's my favorite site. Oh yeah, Fusion Beat. And those are capture beats. Yep. So there's more rules than what I said, but that's just kind of how I envision it anyways. So, okie dokie, guten bye.